Facial injuries. This is our second PowerPoint that you'll be watching today or tomorrow or whenever you decide to watch it. And actually, this could be the first video that you watch. So anyway, our little emoji guy here, he's had some issues. He fell on his head and he lost his tooth and he has a boo-boo. So we're going to talk about the types of injuries that little emoji guy could have here. Okay, I want to give you a little heads up. Pictures are pretty gross. So if you're not a fan of eye stuff, just go ahead and try to not look at them. Because some of the eye stuff's pretty gross. Ah! Calvin and Hobbes. Eye anatomy. So one thing to know about this PowerPoint is any place that the font is blue and has a underline is probably going to have a video associated with it that you can see on YouTube. So this video would have some review of the anatomy. Okay, remember that there's 8 different bones that make up the orbit of the eye. You have your superior orbital fissure, which allows your cranial nerves and arteries and veins to communicate with the eye. You have an optic canal, so your optic nerve can go from the brain to the eye. The floor of your eye has your maxillary, zygomatic, and palatine bones. Medially, your lacrimal, ethmoid, maxillary, and sphenoid. Posteriorly, your sphenoid. The anterior is your frontal bone and your zygomatic bone. Those are the ones that tend to get broken when you have an orbital blowout fracture. And laterally, you have a zygomatic bone and your sphenoid. So lots of bones in the eye. Here's another picture of the eye anatomy. You have your eyelashes and your eyelid and protective layers of the eye. So the eyelashes and the eyelid are trying to keep the dust and the dirt out, in addition to, having a place to put some mascara or some eye makeup if you choose. You have a cornea and an iris which protect your eye, and then your conjunctiva. Here's some more pictures. Like the brain lecture, I put a ton of pictures of anatomy in for you to review it. No, there's not going to be any type of labeling on the quiz, but it's still a good review. Here's your eye muscles. Remember, there's 6 of them, and they allow your eye to go laterally, medially, up and down, side to side. So when someone gets injured or they have a concussion, one of the things that we always do is assess their vision. So an assessment of vision, obviously you're going to ask the important questions like, does your patient wear glasses? Do they wear contacts? Have they always had problems with their eyes or not? You're going to look for nystagmus, which is that side-to-side motion of the eye back and forth. It's a very subtle, very quick back and forth nystagmus. Some people can actually voluntarily do this. I don't recommend that, but they can, so be aware. It's sort of like a party trick, like flipping your shoulders. Never a good thing. It's good to remember if you have a patient who is an older patient or even a younger patient and has diabetes, that is going to affect the eyes. Diabetes affects the eyes and it affects circulation. So that's something to think about when you're evaluating somebody's eyes. Photophobia, so bright lights in your eyes. People who have concussions and bad concussions tend to get photophobia. Scratchiness. That sensation of having something in your eye like sand in the eye could indicate a corneal abrasion. And then there's your, basic itchiness from allergies or infection, which makes the eye pink or just really itchy. What's the mechanism of injury of most eye injuries? Obviously, if you get hit in the face with something larger than your eye, you could destroy the bony margin of the eye, get a pretty good black and blue mark. Objects that are smaller than the eye can actually cause a direct blow to the eyeball itself, rupture the globe. And then chemicals, so like in science class, which is why you want to wear your safety glasses. With hard objects and small objects injuring the eye. That's the reason that for sports like racquetball or squash, or even now for women's lacrosse, you're going to see more patients and more athletes wearing eye protection. In softball now, the infielders all wear a face mask, and this is because there's softball players that get hit in the face and it ruptures their eye or it ruptures their face. So protective eyewear to protect the eyes and protect the outside of the eyes are becoming more and more common in sports. So you're going to look at the periorbital area, the area around the outside bones of the eye, to see if someone, when you're doing an inspection, you're going to inspect the periorbital area. So you're going to look for discoloration of the eye. You're going to look for a black eye, which obviously could also indicate a broken nose, but blackness under the eyes themselves, any kind of gross deformity. And let me tell you that eye deformities are pretty gross when they're deformed. Okay, so loose skin under the eye or around the eyelid area. You're going to look at the globe, so that's the eyeball itself, to see if it's bulging in and out of the eye socket or the eye orbit. And endophthalmos is a posterior bulge, so that's basically the eyes are sitting in a little bit, and exophthalmos would be an anterior bulge, so like eyes popping out. And there's some pictures of those later on in this PowerPoint. You always want to look at the eyelids and see if there's any swelling, ecchymosis. There could be a laceration or a stye, which is like a little red bump on the eyelid itself. Okay, the cornea should be clear. If there is any kind of blood in the anterior portion of the eye or hyphema, you'll be able to see that pretty easily. So here's your periorbital inspection. Okay, so there's the periorbit in that top picture. On the bottom left, you can see the swelling of the eyelids, usually from allergies or a foreign body infection. And then you could also have the right side, which is Graves' disease, which is actually a thyroid disease that you'd see more in your general medical, but it causes bulging of the eyes. More inspection. There's so much inspection, the eyes. You want to look at the conjunctiva. So have your patient look up and down. The conjunctiva is that thin layer that's in like over the eyes, but it's pink underneath the lower eyelid and the upper eyelid. So if the patient looks up and down, that should be clear. And if it's not, that's an indication of some sort of an injury or infection. So you can get pink eye, which is also more medically known as conjunctivitis, which is an inflammation or bacteria in the conjunctiva of the eye. It will get pink and crusty and itchy. It's very contagious, so if you suspect any of your athletes have it, everything needs to be washed. Pillowcases, towels, no sharing, things like that, okay? You want to look at the sclera. If there is a black object in the sclera, that is not good. In the iris, you would look for irritation of the iris. And most importantly, you want to look at the size and the shape of the pupil. Okay, it should be equal. If you have anisocara or a teardrop-shaped pupil, say that 3 times fast, teardrop-shaped pupil, that could be an indication of a corneal laceration or a ruptured globe. So these are all things to look at. And there's some very graphic pictures coming up. This is not a graphic picture. This is just a picture of your eye. You can see where the conjunctiva is, the iris, the eyelid. And here you can see the sclera. So you can see all the different parts of the eye. Top left, you have your anisocoric. You get to hear me sound out words on this lecture. That's when the pupil in one eyeball is a different size than the other, which could come from an eye injury. It could come from a concussion. It is a sign and symptom of a concussion. And so if you have an athlete that comes off the field and they tell you that they don't feel well or they were hit in the head, one of the things you should observe for is that are their pupils equal and responsive to light. So that's what you're looking for. If you have a corneal abrasion, if you look at the bottom picture, you can kind of see where the top of the eyeball is not as clear on the right side, the upper right side, probably between 12 and 1 o'clock, and that would be a corneal abrasion. And a patient with corneal abrasion will present with itchiness in the eye, feel like they have sandpaper in there. That is something where you need to be referred to a doctor. Drops can be given to help this heal. So it usually takes 5 to 7 days depending on the severity of the corneal abrasion, and you want to protect the eye. So depending on the injury that you see in the eyeball inspection could give you a greater appreciation for whether this is like a brain injury or if this is an eye injury. You're going to palpate the orbital margin, so the top of the eyes, the frontal lobe or the frontal bone, so the forehead. You want to palpate the nasal bone, so the nose, and then the zygomatic arch, and all of the soft tissue around the face, the maxillary region. This slide has a functional assessment video on it, and so that's on YouTube. But basically it's going to give you some ideas about how to do a functional assessment of the eyes, how to look at the eyes, how to have someone read a Snellen chart, which is that chart that has all the letters on the ball and tells you what your vision acuity is. So if you have presbyopia, you have a loss of near vision that usually happens from aging. So you see people in the restaurants and their arms aren't long enough. That's what that is. Also known as farsightedness. You can't see near. Diplopia is double vision. You always want to look at pupil reaction to light. So that is pearl. Are your eyes equal and reactive to light? You do that with a pen light, and all of this is on the functional assessment. You would like to see eye mobility, and then obviously a cranial nerve inspection. So what you'd want to do is, I will pause this lecture for a moment or two, and when you are ready, you can watch the video and then you can come back to the lecture. So hopefully you enjoyed that wonderful video. Here's how you use a Snellen chart, and you can also view the PowerPoint link there, that little YouTube link. You can take a look at that and it will help you understand how to use a Snellen chart. Pretty much it's as basic as you think. You would want your patient to stand 20 feet back from the Snellen chart, cover the right eye and read down as far as they can, then have them cover the left eye and read down as far as they can. You then take a look at your Snellen chart and see what line they're on, and you're in luck because you can look and see, is it 20/20 vision, which is down at line 8, or can they only read to line 6? Then they have 20/30 vision, which would indicate they might need to see a doctor and get some glasses. Okay, different types of fractures. So this is nitty gritty. The pictures start to get really fun here. So a supraorbital fracture is a fracture where the frontal sinus is fractured, and usually the brain can get injured as well. It's often showed as a depressed area. So if you look at the top picture on the dude's left eye, is pretty damaged. And then on the bottom picture, you can actually see where the bone is fractured. You always want to be careful to make sure that the dura is not torn. So that is the dura in terms of the dura mater of the brain. Because the brain actually does sit just behind your eyes. If you took off your top of your head, you'd see that the brain sits just below the eyes and almost to the nose. So when you think about where your eyes and your nose are in relation to your brain, it makes good sense as to why damage to the eyes and the nose could affect the brain. You can also have another kind of supraorbital fracture called an ethmoid fracture. And so if you look at the top picture here, you can see the cribriform plate. The brain actually sits right there, and you can see the olfactory bulbs and the olfactory fibers, nerves from the olfactory, that cranial nerve. Helps you smell. So if you have an ethmoid fracture, which this woman below does, it doesn't look like a very pretty picture. She was probably in some kind of a motor vehicle accident where she got her face bashed in. Anyway, you have to worry about more important things like synovial fluid from the brain leaking. It could leak out of the nose. It could leak out of the ears. This type of a fracture, a blow to the bridge of your nose, tends to require surgery and go to the doctor. Here this guy is again, couldn't get enough of him, with his blowout orbital fracture. This can occur from a direct blow to the eye, so a good sucker punch. What will happen is you can have a flattened face, you can have numbness, obviously, because the nerves are going to come down. All of your cranial nerves come down through your face, so that's really important. You could have epistaxis, which is a bloody nose, altered vision, swelling around the eye, double vision, impaired movement. So all of these are, all these signs and symptoms go with a blowout orbital fracture. Here's your anatomy of the orbital fracture. There are so many bones in and around the face and the nasal bone that you want to be aware of that. I will tell you that I had a goalie once who went out to block a shot, a soccer goalie, and he got kicked in the face and fractured his entire maxilla and his orbit. And they actually had to put a metal plate where his maxilla and his zygomatic arch were, so they had to put his face back together. It was pretty bad. He retired from soccer. There's also blowout fractures, which is the floor of the orbit. And so when that happens, you also want to rule out a globe injury, so an injury to the eyeball itself. And the way that you want to do that is to assess the visual acuity, visual fields, the ability to move the eyeball. Can they see proprioceptively? Can they see clearly? And doctors can do things by using fluorescent lamps or silt lamps in order to check the eyeball and make sure that there's no damage in it. So signs and symptoms of orbital fractures overall is your double vision, sunken eyeballs, impaired movement, a hanging drop in the maxillary sinus, a lot of damage to the face overall. So this guy here, he's all better now, but you can see in his pre-picture where the damage is on the medial aspect of the eye, and then you can see where he's all healed up where they did surgery. He's still a little puffy there on the right side, but he looks a lot better. If you have double vision with an upward glaze, 90% of the time it suggests an inferior blowout. Which means that the inferior rectus and inferior oblique muscles of the eye are entrapped. If you have double vision with a lateral gaze, so off to the side, 10%, that often suggests a medial fracture, which means that the medial rectus muscle of the eye is unable to move the eye medially. So how do you treat this? Sometimes it fixes itself without surgery, but often you want to go to the doctor and have an orbital fracture treated. Sometimes, most often, there's going to be some sort of a surgery, a bone graft, or some sort of a plate in order to fix it. Here's some other types of eye injuries. You can have an abrasion. You can have foreign bodies from your eyes getting impaled, lacerations, burns from any kind of like an acid or a flash from a really bright light could also cause flashes to the eye, damage to the eye. So if you get anything in your eye, like you're in lab in chemistry and you want to get all the stuff out of your eye, or who knows what you're doing, but you want to irrigate the eye with soap. Just kidding. Wanted to see who was still awake. You want to irrigate the eye with clean water, usually with saline, and clear it out. And then probably see your patient's doctor and refer them to a doctor. If you have a blunt injury to the eye, there's going to be swelling, hemorrhage, bleeding in the eye, a ruptured globe. You could have a blowout fracture of the orbit, or you could have a retinal detachment. A retinal detachment, the symptoms of that are usually sensation of little black dots or a veil or a screen. Patients complain of seeing black, like a black veil or black screen going over their eye, and that does not resolve itself. And retinal detachments are not going to heal themselves. They do need to see a doctor. They can be repaired sometimes, but not all the time. So that's a retinal detachment is a pretty serious injury. So here's some good pictures of some globe injuries. Getting pretty gross. I think this is a pretty gross picture. I'm not sure about you guys. This can come from a contusion. Your signs and symptoms are going to be your loss of visual acuity, blood in the anterior chamber, the pupil will either dilate, which is get big, or constrict, and usually it's a lot of pain, and there's some pupil irregularity. When you're talking about injuries, you always want to consider C-spine precautions due to the forces required for an injury. So did this injury occur as a really hard whiplash or from a blow to the head? If you cover your eyeball, if you cover someone's eyeball because you think they have an injury and you want to cover the eye, do not put any pressure over top of the globe, because if the globe is injured, if you have an injured eyeball, you can cause more pain to that. So you just want to cover the eyes loosely, but you always want to cover both of them for protection. And then obviously avoid activities that increase intraocular pressure, like going up in outer space or going on one of those amusement park rides where the centrifugal force pushes you against the wall and then the floor drops. Probably not a good thing to do if you got an eye injury. Less pressure, the better. All right, moving on. Moving on to ears. This is a cute little ear of a little baby. Here's the ear. What do you hear in the ear? So you have your ear anatomy. You have an external ear, a middle ear, and an inner ear. And I think you guys all probably know by now that the ear is mostly responsible for hearing and balance. You got that, vestibular, cochlear, central cranial nerve. That's a good thing. So this is just a quick review here on the anatomy. Here's another one. There's the semicircular canals. The semicircular canals are mostly where balance and like equilibrium actually take place. And that is also where the sounds are conducted, through the semicircular canals. So the air goes into the ear, or sound, and it goes through the tympanic membrane, which causes the Inca, the stapes and the hammer to vibrate, which then causes the sound to go through the semicircular canals and into the cochlea, which is filled with little cilia, and the little cilia vibrate back and forth, and that's what sends the sound to the brain to be turned into sound that you can actually understand. It's pretty cool, actually. The ear's pretty neat. In order to do a ear evaluation, I have found a very neato ear evaluation YouTube video. I do know that we did not get to otoscopes, and we will get to those. You will get to that before you graduate, how to use an otoscope. We'll do some general medical review. So throughout this second semester that you're with us here, spring semester, not second, but spring semester, we'll go over that kind of stuff. So when you get a chance, go ahead and take a look at this video. So I only listed a couple ear injuries in this slide presentation. You'll see more as you go along in your life, but cauliflower ear is a big one for those of you who decide to go work at a high school or a college that has a lot of wrestling. It is pretty gross. It is an inflammation of the pin of the ear due to excessive friction. So basically, as wrestlers who choose to not wear ear protection, most of them do have to wear ear protection now, but the ones who choose to not get ear protection, during wrestling, their heads basically get smushed on the mat, and they get rubbed against the mat, and ultimately fluid fills between the layers of skin on the ear. Over time, it will harden because it's like anything else in the body. If you keep applying enough force to something in the body, like say you keep hitting the quad over and over again, ultimately bone will form in that area. It will calcify to try and protect the area. So if you keep rubbing your eardrum or your ear, outside of your ear, on a mat, eventually it's going to swell, and then eventually it's going to harden. The body stops absorbing the fluid. So cauliflower has a lot of different degrees. It's pretty disgusting. Usually we prevent this from even happening by using ear guards during wrestling. You'll see this also in rugby players that get in the middle of the scrum that don't tape their ears back. Cauliflower can be drained by a doctor. There can actually be surgical, you can have a surgical intervention, because if you can see, the actual auricle canal does get smaller and smaller if the outside of the ear gets really swollen, and then it impedes the ear's ability to get the sound through there. So we don't like that so much. Here's another common injury that we see in mostly in swimmers: otitis externa, which is outer ear infection, or we call it swimmer's ear. So a lot of the time there's an infection in the outer ear. There's pain, there's clear discharge. Sort of one way that we check to see is, and there's no science behind this, but if you have the athlete pull on their earlobe, just pull down on the earlobe, and they complain of pain in their ear, a lot of the time that's a sign of an outer ear infection or swimmer's ear. And it can be treated by going to the doctor and getting an antibiotic or drops and keeping the ears dry. Otitis media is a middle ear infection, and this is a little more serious because the middle ear has the Inca and the stapes and the hammer, which are the primary bones, the auditory bones that vibrate in order to get the sound into the inner ear to get it into the brain and through the eustachian cords and eustachian tubes. So with otitis media, that's a little more serious, and the signs and symptoms of a middle ear infection are there's pain, your patient will complain of dizziness, not feeling well, but usually it's pain and dizziness, difficulty hearing because there's fluid in the middle ear that can be infected. If the doctor looks in the ear of the affected patient, they'll see at the bottom there that tympanic membrane is very pink and irritated. A regular tympanic membrane should be translucent. You should be able to see through it. So if you guys look in each other's ears, you're going to see that the tympanic membrane is pretty translucent. You shouldn't really be able to see much through it, but if you have an ear infection, you will see the fluid levels, and it creates a lot of pressure in the ears. It's very uncomfortable. So when you have a patient who comes to you that says, my ear's hurting, I feel a little nauseous, I feel a little dizzy, it is important to take a look in their ear. These types of injuries and ear infections, sometimes ear infections are secondary to sinus infections. Sometimes ear infections are secondary to like the flu or some kind of general medical condition. The ear should always be checked because they're pretty vulnerable, and your patient can actually lose their hearing if it's not followed up on. So there you go. A ruptured tympanic membrane, which is a ruptured eardrum. How do we rupture our eardrums? Eardrums can be ruptured from loud sounds, but more commonly than not, a ruptured eardrum will occur from increases of pressure. So you hear about scuba divers and the pressure, they don't release the pressure, they don't swallow properly. That can cause a rupture of the eardrum itself, and that will cause, there'll be bleeding. Another way that eardrums can actually get ruptured is if you have an athlete or a patient who goes on an airplane with a pretty good head cold or a sinus infection, there's already pressure in the ears, and going up in an airplane can actually cause rupturing of the eardrum. If that occurs, if you think you have a patient who has a ruptured eardrum, their ear's bleeding, they have extreme amounts of pain, they can't hear, they do need to go to a doctor immediately. Usually a ruptured eardrum will repair itself. It just needs, no water in the ear, antibiotics, and a doctor to double check it and see if there's any type of infection or treatment that needs to be done. All right, we're coming to the end here. This was a longer lecture than I thought when I made the slides, but apparently I got through it pretty quickly because we're only at half an hour, so that's kind of good. But this guy, he lost his nose, didn't have a good day. Nose anatomy, it's important to know about the nose anatomy basically because the sinuses around the nose, your hard palate and your soft palate are the top of your roof of your mouth. As you get into athletic training and as you get into working with patients, you're going to have patients that have chronically drippy noses, could be from allergies, their sinuses can be congested. So all of that is important stuff to know about. The nose, like the ear, is a pretty basic part of the face. If you have a broken nose, obviously it will need management. Nosebleeds are pretty easy. There's a link below that's going to show you some management for nosebleeds. The only thing it does not tell you is that you have an artery that is on your upper lip between your teeth and your lip there. And if you have someone who has a nosebleed and you cannot stop the nosebleed, if you roll up a piece of gauze and stick it just above their teeth, under their lip, a lot of the times it will compress that artery and it will control the bleeding. If you have an athlete who has chronic nosebleeds, like they bleed constantly as soon as the weather gets cold, sometimes Vaseline is just regular Vaseline on a Q-tip is a good way to cauterize that naturally. But if the nosebleeds continue, that's something that we need to see the team physician for. So go ahead and take a look at the video at your leisure. And that's pretty much our nose, getting there for the nose. So there is a lot of there's a lot of info in this lecture. I'm going to guess you guys probably know, aside from the orbital fracture information, you've probably covered this in your first aid classes, emergency management classes, but we will review this over the holidays. I promised you I wouldn't inundate you with a ton of material. So I'm going to say happy holidays. Please do not forget to do the quiz, 10-point quiz, and it will be over this lecture and the head lecture. So hopefully this wasn't too painful and you have wonderful holidays and you relax and unwind, and we will see you in the spring.